Welcome once again into the Radiopedia reading room for a podcast unconcerned with books or poetry, tea leaves or palmistry. It's a radiology podcast. My name is Andrew Dixon, and joining me, I think he's stalking me, to be honest, because I swear I saw him loitering around my radiology department the other day. It's my co-host, Frank Gaylard.
I am stalking you, Dixon. I am indeed, but it's official sabbatical stalking, so it's okay.
Is it?
Funnily enough, though, I've been at your hospital and I've interacted with your so-called colleagues. I've still to find a single person that admits to even knowing who you are. Or are you sure you work there? Or is this some sort of elaborate, what's his name? Frank Abagnale from, Catch Me If You Can of con, where you've pretended all this time to be a celebrity radiologist. But in fact...
Yep. You've caught me out. I don't actually have any radiology knowledge. Now, there is actually a running joke at work because I've been taking long service leave every second week to do Radiopedia stuff. I've been given the nickname 1 in 2. and then some colleagues decided to take it a step further and they started calling me 1 in 3, which is unfair. I do work 1 in 2. And then now it's even got to the point where a few of them have started calling me 1 in none. And this is 1 in none. Here he is. I've made things worse, though, for myself because I have taken to jokingly introducing myself to our fellow every time I walk into the reporting room. Like I've never met him before. It's like, oh, hi, Andrew Dixon. Nice to meet you. And you are...
It could be worse, though, because a couple of years ago, I took some leave at the start of the academic year when registrars were just starting. And when I came back a few weeks later, I saw a group of registrars in the hallway. So I went up and said hello. And there was this one guy who I'd never seen before. So I reached out and shook his hand and made a big show of welcoming him to the department and introducing myself. And it was really awkward because everyone was just staring at me. And after a while, he cleared his throat and said, I'm Tom. I've been here for 18 months.
That similar thing actually happened to me the other day, but I stopped myself just before I did it because I looked at this guy as I walked into the reporting room and I was like, oh, he must be one of the new registrars. I'm pretty sure I haven't met him. I should introduce myself. And then just as I was about to do it, I was like, oh no, he's that new consultant who's been here for about 6 months.
That's a sign that we're getting older, Dixon. They're all looking young.
Oh, they're all so young.
I had 4 of my registrars who are coming up to their exams because I'm on sabbatical now. I'm not giving any tutes at work. So I invited them over for a sort of practice exam at home and dinner. And so my kids were there. And one of my registrars is significantly shorter than my 11-year-old. And she was sitting at my desk. And I burst out laughing halfway through the practice exam because I noticed that she was literally swinging her legs on my chair. So they're all babies. And we're old men.
So today's main segment, Gaylard, has changed, actually. Not sure if you got the message about that one. So,
I did.
Yeah. So I had planned this other one, told you all about it, but it's been delayed a little. So instead, I've dug out a panel discussion that I recorded last year at Radiopedia 2023. Dug out sounds bad, but it's good. Trust me, it's good. Like digging up a golden nugget.
Hey, you know how when you're at the beach, you fairly frequently see someone wandering up and down with a metal detector? I've never understood, to be honest, why they would do that. I'm sure occasionally jewelry's dropped, but it can't be that common to justify the expense of buying the thing and the time spent. But anyway, some guy in the UK found a gold nugget worth $50,000 or something. Can you imagine that? That's just finding it. And can you imagine the real winners are the salesmen of metal detectors? Now everyone's going to be disappointed when they don't find a $50,000 nugget.
No, the real winners are the partners of those people who get out of having to talk to them for hours. Off you go, Frank. Do a bit of prospecting. Don't hurry back.
Get out of the house.
No, I saw that story, and it was the biggest nugget ever found in the UK. It was 60 grams.
Yeah, that's right.
The Australian ones, the biggest ones in Australia is 80 kilograms.
What's it called?
The biggest one.
Welcome Stranger?
Yeah, Welcome Stranger. Yeah.
So if people are not familiar with the gold nuggets of the world and you can't immediately picture the Welcome Stranger nugget, you have to picture something significantly larger than the largest watermelon you've seen, but really craggy and looks geographical in shape. It's massive. And then this UK nugget is significantly
The
smaller
size of
than
a 50 pence coin or something.
Yeah, like a grape.
Yeah, that's not a nugget.
This is a nugget.
There you go. There's a Crocodile Dundee reference for everybody.
Well done.
I reckon it's another example of those small dopamine hits, right? So that's the only reason they could be out there on a windy, rainy day scouring the sand at the beach, right? It's like scrolling through TikTok or YouTube Shorts. Most of those little videos are absolute crap, but occasionally you get this golden little video that entertains you. That's enough reward to keep you going. There's always that slight chance something good is just around the corner. Much like our podcast intros, Gaylord. If we keep banging on enough, something good might happen.
Any day now, any day. I remember actually reading years ago about a study on chimpanzees looking at the evolution of ritual. Like, I don't know why I was reading this, but it was actually really fascinating. They built this contraption that had like 4 buttons on the front and a little slot that would deliver pellets of treats, like a raisin or something. And the buttons were not connected to anything. The slot would just occasionally, randomly deliver a little treat. And so anyway, there's this chimp sitting in the room, scratching himself, and or herself, don't know the gender of the chimp, and a little treat comes out, and he picks it up and he eats it, and it's like, oh, that's tasty. It's like, how do I get it out? So he sort of hits the machine a bit. Eventually he hits a button, and it happens to coincidentally a few seconds later, another treat comes out, and he's like, awesome, I've worked it out. It's the button. So he hits the button, but nothing happens. So he hits it again a couple of times and then scratches his head. And then the little treat comes out and he goes, aha, it must be 2 hits of the button and scratching my head. So then you see, and what they found was that as long as the behavior seemed to be rewarded about 1 in 10 times, that was enough to maintain the ritual. And these chimps ended up coming up with these really elaborate sort of ritualistic behavior that took forever.
They wrote Romeo and Juliet.
Yeah. An entire new religious cult worth of rituals. So I reckon TikTok and Google very much are on that 1 in 10 if you're lucky, you know?
Yeah. Same with the podcast intros. But you'll be happy, Gaylord, because this one today, so this is a head and neck conference panel that I've got for you, focusing particularly on tips for trainees. And speaking of the conference, Gaylord, I know you saw the speaker announcement email that we sent out earlier in the week with the speaker cards that Emily came up with. I just wanted to give a shout out about those.
They are really, really good.
For those people who haven't seen them, so they're like a board game style card with a photo of each speaker and some details about their super skills that they'll be bringing along to the conference. They look really, really cool. And over the next few weeks, Emily plans to make one of those for all of the, 50 or more speakers involved in the conference. I think we'll also make up a little page on the website to feature them so people can enjoy them.
They are very much World of Warcraft trading card game inspired.
Yeah.
I'm guessing you're not much of a trading card player, are you?
No. I just appreciate the design style of them.
Well, I'm sure that it will shock you and our dear listeners to find out that I have, in fact, played a number of these games.
Who would have thought?
I know.
This reminds me, the other day we went to an Auntie Donna show at the Comedy Festival. Auntie Donna, they do like kind of absurdist comedy, kind of an improv show as well. And we were lining up for it. And we looked at the crowd and we were like, are these like the smelliest people you've ever been around? It was like considerably younger than us, lots of males, late teens, early 20s. And Belinda said, wife of the podcast, said that it reminded her of a smell she smelt one day when she walked down into like this little kind of dungeon shop where people were playing World of Warcraft. And she walked down there and the stench just hit her. And she was like, that is the smell that I smelled at this comedy gig.
That's the odor of neckbeards.
Yeah, exactly. It was amazing. Now, Gaylord, I saw you made the mistake of asking Emily specifically to include you chose a specific photo of yourself to go on your card.
Well, more
which
importantly,
is a rookie error, especially the day before we record a podcast, to go, oh, Emily, do you mind just using this photo of me? Like, nah, that is not happening, mate.
More importantly,
you are getting one with a goat-themed card for sure.
Well, that's fine. It's just the one photo that you keep using is the one of me with a beard. And in my entire 50 years of life, I have had a beard for a total of 4 weeks, and that one photo is going around.
No. Emily, if you're listening, Murph, please send this to Emily. I want Gaylord, full Teen Wolf kind of, just hair everywhere, maybe a golden nugget or 2. That's what I want for him.
Goat horns.
Goat horns. That's what we want. All right, we better get to this week's panel discussion. So this is me chatting with 2 delightful Americans, Daniel Gewolb and Tabby Kennedy, about head and neck radiology. It took place just after Tabby had given a lecture entitled Neck CT Search Patterns and Check Areas, and Dan an equally fantastic lecture titled Spaces of the Suprahyoid Neck. Both can be found in the Radiopedia lecture collection over on the website. So let's listen in now, and then Frank and I will be back to uncover a few more nuggets in the outro. So joining me now are the 2 speakers we've just watched. So Tabby Kennedy and Dan Gewolb. Thank you both for those fantastic lectures.
Thanks, Andrew. I'm super happy to be here for sure. Radiopedia has been a huge part of the education process for me throughout residency, so it's just kind of awesome to be able to give some support back.
Yeah, thanks, Andrew. I'm really honored to be a part of the conference, and I am really excited to kind of dive a little deeper in this conversation today.
Yeah, let's do that. So they were both beautifully kind of pitched at the trainee level, those talks. And head and neck can be one of those areas it's quite intimidating to newcomers. So I think people around the world will really appreciate those talks that you put together and the efforts you put in there. Actually, Dan, originally the convening team had me penciled in to give a talk on the deep neck spaces, but I noticed your awesome tweets that you've been putting out on Twitter and also some cases that you'd uploaded to Radiopedia. So I thought I'll reach out and see if he wants to take over from me. I'm very glad I did, because that was a fantastic lecture.
I was super happy when I got that email. Honestly, I was like a little kid on Christmas. I got so excited. Just education has been something I love to do, and you see the effort I put in on Twitter there, as well as kind of the lectures I prepare for residents and medical students throughout my residency, and now hopefully to continue into fellowship. And just education is something I kind of look to do for the rest of my career, and it's something I really much enjoy.
It's a very rewarding thing to do, but look out, because it amplifies, right? You put yourself out there, and then people like me will go, "Hey, Dan, come and be on the conference." So tips for trainees is really what I want to focus on in this session. So I've written a few things down inspired by your 2 lectures. So Tabby, your lecture was really focused on developing a reproducible search pattern for neck CT to really ensure that you systematically cover everything every time. So I guess in your experience, is there one part of the search pattern that trainees most often neglect?
So I guess I'd say that in my experience, the hardest part for the trainees, and really honestly for any radiologist who's interpreting neck imaging, is seeing the second or the third or the fourth finding. Oftentimes our referring clinicians will, ask a very specific question, is there tonsillitis? Is there peritonsillar abscess? And it's really our job to figure out, okay, yes, we want to answer that question, but is there a secondary or third finding? And so I feel like it's easy for us to see the 3-centimeter mass, but it's harder for us to see those more subtle findings. So I think that honestly, search patterns really help with that. You can certainly answer their question, but you really want to be able to default on your search pattern and then look for, everything on the scan. And so I'd say that, beyond that, more specifically, the trainees tend to overlook the vasculature. So if they are doing a CTA, of course, you're going to look at the carotid arteries and the vertebral arteries and the veins. But with a neck CT, I think, people are kind of distracted with all of the soft tissue findings. And so I think to really focus on the vessels, looking at the carotids, the verts, looking for dissections in patients that might come in with neck pain, look for vascular or venous occlusions. And then I think another blind spot for trainees is seeing the corner shots. So on our neck CT protocols, we tend to include the posterior fossa. So we catch a little bit of the brain or the cerebellum. And so you definitely really want to, focus on looking at the brain to look for, intracranial mets, and then also potentially looking at the lung apices. And then I think finally, the trainees tend to miss things at the midline. So retropharyngeal effusions, for example, in patients that have calcific tendinitis. So I feel like that's often a blind spot. And then also lateral retropharyngeal lymph nodes. And I know Dan really focused on that in his talk, which was great. But that often is something that the trainees and particularly the residents will tend to overlook.
You mentioned that retropharyngeal effusion and longus colli calcific tendinitis. That reminds me of a story. When I was a junior consultant, I had one of our trainees who, on a CT cervical spine, mentioned that they thought there was a bit of fluid in there. And I removed it from the report. I thought, it's probably just a bit of prominent adenoidal tissue. There's nothing there. Anyway, subsequent MRI, there's definite fluid. And then in retrospect, there's a little bit of that amorphous calcium sitting just under the anterior arch of C1. Yeah. And I was like, oh my gosh, should have just gone with the residence report.
Yeah. Trainee or faculty could also miss these findings.
Exactly. That's what I thought. Maybe I'll just step back and let her put out the reports without my help in the future. Dan, thinking back to when you started out with your trainings, not that long ago for you, were there any tips or words of advice that helped you to become more comfortable with assessing CT neck?
Yeah, for sure. Definitely not too long ago for me. As a just starting fellowship now, I got still lots to learn for sure. But I would say something that was really helpful for me at my institution in particular, CTA head and necks, as well as the CT cervical spine for traumas and things like that, were some of the most common studies. We do those day in and day out, every hour or so or less. You're going to get a study like that. So since those were so common, I kind of treated every one of them like a CT of the soft tissue of the neck. Like, as you mentioned, it can be kind of intimidating as a junior trainee to tackle your first CT soft tissue of the neck. But if you treat all the CTAs like that, and if you treat all the CT traumas like that, then you can develop that search pattern. You can kind of really start to understand what normal looks like and learn the anatomy. It just provides a really good foundation for when you start looking at more dedicated CT soft tissues of the neck. So that's something I think was a big help for me.
I love that. It's kind of two birds with one stone, isn't it? Because not only are you reminding yourself to look at the soft tissues on the CTA and on the cervical spine CT, but you're also then, getting your eye in for when you are doing a dedicated soft tissue neck CT. I like that.
And as Tabby mentioned too, it then kind of helps for the other way too. Then when you start doing the soft tissues of the neck, and then you start thinking, I got to look at the carotid bifurcation, I got to look for aneurysms, dissections, and things like that. So it helps for the vasculature as well.
And you mentioned getting used to kind of normal anatomy there. And, tonsillar tissue was something that you specifically mentioned in your lecture, Tabby. And Dan, you mentioned the pterygoid venous plexus. And I guess along with prominent lymph nodes in young adults, these are some of those normal things that can look quite striking to a newcomer, particularly on MRI, actually, because they're quite bright on MRI. Tabby, have you got any tips for dealing with these kind of normal structures?
I think that honestly, repetition is key. So you really need to be able to see a lot of cases to be able to understand what normal looks like. And normal can look different in a pediatric patient and look different in a 20-year-old, 30-year-old, and then look different as patients get older. And so really to kind of understand, repetition is kind of key to be able to really understand what normal is. I'd say that if I encounter something that, it happens to catch my eye and I'm not sure, is it normal? Is it abnormal? And I find that particularly in pediatric patients, it's like, is this something that, is expected to be normal? Maybe even more in temporal bone CT or, in other parts of, the CNS. What I'll tend to do is try to see if I can find other examples of normal on my PACS. And so, kind of just search the PACS and see, okay, I'm going to just try to find brain MRIs or neck CTs or CTAs in that, patient age group, and then just pull up, 5 or 10 cases to try to get a sense of, is this a structure or is this something that, I would expect to see? And then also you may have, a teaching file at your institution. So maybe they might have a set of normal exams, of patients of different ages. And so I would say that's another potential place to look.
Yeah, looking at other studies is really, really important. I've definitely had this. You guys have probably had it as well, where you report something as being abnormal on one scan. You go, oh, that's a bit unusual. You report it as being abnormal, and then you look at the next 3 or 4 studies that come through, and you're like, it's
I've
the
definitely done
same
that.
thing again. Yeah. So you got to dial it back, but to try and avoid that kind of cognitive error, looking at other normal cases at the time, and I think Frank Gaillard said this the other day, like if you're calling an abnormality that you've never called before, if it's the first time you're calling, a parotid gland that looks way too low density, then maybe hang on, have a look at some other scans, because you realize that actually the parotid glands actually look really, really low density. They're less dense than water. They're very quite fatty often on CT. So those kind of things, anytime you're making something up for the first time, just double think about it. So teeth, I've written here, teeth time. Tabby, you mentioned that you specifically look at the teeth and the alveolar bone in quite early in your assessment. You kind of start with the lung apices and then switch it on to bone windows and look at all the bones, and then look at the teeth as part of that. And Dan, you showed that a really important pathology in the masticator space is infection arising from the teeth. So Dan, have you got any tips for not missing or undercalling those dental infections?
Some of them could be really, really tiny, some of those subperiosteal abscesses. So it's important to kind of look hard. And usually the way I handle it is I kind of get a lay of the land on the soft tissue window at first. And then once I see kind of where the swelling is and where it's kind of localized to, then I flip it to the bone windows. You can spend a little bit more attention to the teeth, for example. And then once you see that periapical abscess or lucency, and you kind of look really closely for that area of cortical dehiscence, whether it's on the lingual or buccal side, once you see that dehiscence, though, that's kind of where you're in the right spot. That's where that subperiosteal abscess is going to rise from. So, once you see that on the bone window, you can then flip it back to the soft tissue window and really kind of hone in on that area and make sure you see sometimes very subtle, very tiny subperiosteal abscesses.
Yeah, there's a lot of very, very subtle ones, isn't there? Tabby, you had something to say?
Yeah, I was going to say, oftentimes, for me, it really depends on, are they coming in with something that is referable to the dentition? So does the patient come in with some sort of facial swelling or dental pain where that's actually the clinical question? And so I find starting off with a clinical history, they might say asymmetric facial pain, mandibular tooth pain. So they're giving you the history. And so exactly where to look in that situation. The other scenario is more of an incidental finding. And so it's like, you can have a periapical abscess. What does that actually mean if you have a lucency there? Is it actually something that is symptomatic or not? And so I think that they're kind of two different scenarios. But in the symptomatic patient, I think starting off with the history first, looking at the soft tissue windows, as Dan had mentioned, and then it's got to come from somewhere. And so oftentimes, if you've got facial swelling, it's likely going to be coming from the teeth. And then trying to, pinpoint exactly what tooth. And then I find, really looking at some of your reconstruction. So at my institution, we tend to like our reconstruction. So we have soft tissue and bone windows in axial, coronal, and sagittal planes. And I find that looking at the coronal plane can be really helpful because there's so much artifact often from dental amalgam that can really distort your ability to see the teeth on your axial plane. So looking at your coronal reconstructions, and that might reveal a subperiosteal abscess, with some adjacent inflammatory stranding. So I tend to use my coronals. And then in that same vein, I find that if you've got a patient with a dental infection, particularly at the midline where that infection is extending posteriorly into the oral cavity, you definitely really want to make sure that you're looking at the oral cavity as well for, kind of secondary extension, in a Ludwig's angina kind of situation. Mm-hmm. So you want to make sure that you're looking at the floor of the mouth. And I find that coronals tend to be really helpful for that.
So we've mentioned fat stranding there, looking for that kind of inflammatory stranding. I'm sure both of us very much appreciate the elegance of that fat-containing parapharyngeal space in the central, kind of a central landmark in the suprahyoid neck, and how it's pushed and distorted, and that can help us, localize pathology, detect pathology as well, and then come up with a nice differential diagnosis, and sometimes just a single favored diagnosis. And Dan, you went through that beautifully in your lecture, so I'm not going to repeat it. But aside from the parapharyngeal fat space, Tabby, do you have like other helpful little spots in the head and neck that you like to look at and maybe impress upon residents?
I do love that parapharyngeal space fat. That is definitely a good one. So there are so many fat containing spaces that I find looking at that normal fat, on a T1 weighted MRI without any fat sat and no contrast, or a neck CT, looking at that normal fat is so helpful. So I find the premalar fat and the retroantral fat, or that retromaxillary fat, is really important in assessing extension of sinus disease, spread of infection outside of the sinuses, particularly in those patients that you're worried about invasive fungal sinusitis. So looking at those spaces just anterior and posterior to the maxillary sinus. I also find, the pterygopalatine fossa fat to be really helpful, looking for perineural tumor spread. That's going to be a subtle one. You really need to, kind of have your antenna up to be looking at that space in particular for perineural involvement. And then I'd say probably the third one would be the preepiglottic or paraglottic fat. And that's really more important when you're trying to stage laryngeal cancer, because if you've got involvement of that fat pad, that's going to upstage that patient to a T3 lesion. So kind of understanding how that fat and involvement of the fat will help you in terms of your diagnosis of that individual.
Some great little spaces you've mentioned there. With the retromaxillary fat, I think I mentioned this in a panel last year, but I had this case where, an intensive care patient, they've got a little bit of fluid in their paranasal sinuses on CT, and I just saw a little bit of stranding in that retromaxillary fat, and I just raised the possibility, in this setting of an unwell patient in ICU, this could be invasive fungal sinusitis. And I didn't think it was, like, it was very, very subtle. And they did a scope based on that, and they found sloughing off tissue. And I was like, oh my gosh, that was, imagine if I didn't mention that. It was a very, very subtle finding. So that's a great little check area. I know that earlier in the day, Christine spoke about the pterygopalatine fossa, looking for the effacement of the T1 fat in there as well. And the other one she mentioned was the stylomastoid foramen, looking for that little bit of fat around the facial nerve as it comes out there and heads into the parotid. Dan, have you got any like similar little spots or little tricks that you want to share with us?
Yeah, absolutely, for sure. Of course, fat's your friend, especially on MRI, T1, and everything like that. It's one of the most essential sequences and everything. But besides for that, I kind of mentioned this in the talk already, but I really like the displacement of the styloid process as well as the associated muscles when you're trying to differentiate between something that's coming from maybe the deep lobe of the parotid versus the true carotid space. And, so if something, again, if it's arising from the carotid, it's going to push that styloid process more anterior, which narrows that stylomandibular tunnel. And if it's arising from the deep lobe of the parotid gland, it's going to widen that stylomandibular tunnel, push that styloid process back. So that one is really helpful. And then the other one I would say just paying close attention, I guess, to all the nerve foramen, again, the skull-based foramen, for example, foramen ovale, jugular foramen, for example. So, sometimes the masses can be really big. It's tough to tell which compartment they're coming from. And then you see, that the mass or lesion is going into, through the jugular foramen, for example, then you can really localize it. Once you have it localized, the different spaces have a pretty narrow space-specific differential. So, once you have enough, you know the anatomy enough to localize the lesion to the particular space, then you can kind of make that space-specific differential, which is going to be super helpful, going forward.
Yeah, I love that stylomandibular tunnel as well. And the other one that reminds me of is the eagle, and in front of the eagle's neck, under their beak, for the hypoglossal canal as well, as another kind of awesome one on your coronal images. Finally, to end this little session, I just want to actually give a little shout out to two things that I'd really encourage trainees to always think about when they're dealing with an infective or an inflammatory process in their head and neck, because often they're the really urgent ones and serious ones we need to be thinking about. And the first is actually, you showed an example of this, Tabby, in your lecture, to always check for that septic thrombosis, because you will miss it unless you specifically look at the veins for it. Although one little trick there is to be aware that once you've got a little bit of edema and swelling, you can narrow your internal jugular vein off. So make sure you're looking for actual luminal filling defect, actual thrombus filling the lumen, rather than just some narrowing from the edema. And the second thing is never forget to check and mention the effect that the process is having on the airway. I often find myself having to add this into trainees' reports. They spend all their time describing, there's a collection here in the parapharyngeal space or whatever, but they forget to actually say, oh, hang on, the airway is actually pinpoint at this point. So I just want to emphasize that. Don't forget to put a comment in there about the airway. I remember this case when I was first year trainee, night shift by myself, and we had this young lady, and on the first scan, I saw a little bit of stranding in the deep neck spaces, mainly superficial stranding around the face. And then I noticed that she had quite a large superior ophthalmic vein on one side and didn't look very enhancing. So, and we got her back. I reported those findings, and we got her back probably less than an hour later to look for cavernous sinus thrombosis. And the dramatic difference between the two scans, an hour later, there was swelling everywhere. The airway was completely gone. And she did have cavernous sinus thrombosis, and she had a surgical airway immediately performed, and even with that, she passed away. But it just really sticks in my mind how a very subtle finding, and there was a little bit of airway narrowing on that initial scan. Anything is significant, particularly in those rapidly evolving kind of cases. Sorry to finish with a downer.
No, I mean, that's something that's super important. It's great to mention for sure. I think when you're kind of in the reading room or behind the computer, it's something that you can forget to mention, or, if you're not there actually seeing the patient, being able to gauge like how well they're breathing, it's something that you can kind of just forget, but it's so important. And, we're seeing the inside of the patient. So, and sometimes too, like they can have pretty significant airway compromise, but clinically be looking, not too bad. And it can progress very rapidly, like you mentioned as well. So, it's great. That's for sure great to mention. And then since you said that though, it kind of reminded me also at one point, like earlier in my training, the first time you see this, it can kind of throw you off a little bit, at least for me, it did. You got to realize too, when you're talking, or if someone's having, in Valsalva maneuver or something like that, for example, the glottis can physiologically be closed. So sometimes the airway can look like it's totally closed off too, on the other end of the spectrum. But, if you don't see the true swelling there, you don't see a mass or anything like that, you should realize, look on the, different planes and everything, and you should be able to tell that it's probably just physiologic.
Absolutely. It's very, very often closed off there, and that's just normal physiology. And even sometimes, those piriform sinuses can be a bit asymmetric normally as well. But I'm talking about that, in the oropharynx, that kind of area where you can miss quite significant narrowings unless you specifically look for it. All right, let me pick up the mood away from this depressing ending by thanking you both for your excellent lectures here at Radiopedia 2023 and for helping to support the conference. I really appreciate it. People should definitely check out Daniel's tweets on Twitter. He sends out amazing neuroradiology cases at quite a high frequency, Daniel. I don't know how you do it. You mustn't have any children like me.
I do not.
And you do not, no. And everyone should also check out Tabby's website. It's called learningheadandneck.com. Great head and neck teaching cases, including those scrollable images that she showed in her talk. Tabby and Daniel, thanks very much for being here, and I hope to see you both again soon.
Andrew, thanks so much. It was a pleasure working with you.
Thanks, Andrew. Nice to meet you, Dan.
Oh, there you go. Hopefully a few nice nuggets of teaching gold for trainee listeners there from Dan and Tabby. I certainly would recommend, if you're starting out in head and neck interpretation, that you check out both their lectures in the Radiopedia lecture collection. And I should also say that Tabby and Dan will both be returning in July for Radiopedia 2024 with new lectures.
That'll be excellent. I really like the discussion about the sort of mistakes that people make, including how you make different kinds of mistakes at different points in your career. And in fact, on that topic, there's another talk in our lecture collection that is relevant. And that's my talk last year on MRI brain search patterns and check areas, which despite the title and in fact the lecture brief that you gave me is mostly about errors, actually.
Yes, I remember that lecture because I did the CT brain equivalent. And I showed something like 30 different pathologies, covered lots of stuff. And then in your lecture, you showed what? A grand total of one pathology?
Yeah, maybe.
Very much a helicopter view, Gaylard. In fact, I think there was actual footage from a helicopter or drone that you used during the lecture with a bit of
There was
cheesy
all
music.
sorts of things. Yep. I went a little bit off topic, but I have to admit that the older I get, the more I find that I enjoy creating talks that are not just covering a topic. I prefer these ones which allow me to procrastinate more and work out how to include drone shot videos and music.
Which is why we can't just have a conference with only Frank Gaillard content. We need a more balanced program than that. Have you got anything else related to this discussion that you wanted to talk about?
Well, not really related to this discussion, but on a completely separate and yet again unrelated note, did you see the new Boston Robotics Atlas II launch video?
Oh, I assume that's the one. I saw something the other day. There was this robot lying on the ground, and then it contorts itself in some way that the human body certainly couldn't, gets up and starts walking around, and then its head turns around 360 degrees or something. Is that the one?
Yeah, that's exactly the one. And what it made me think is, you know how radiologists are always petrified of AI taking our jobs?
Yeah.
It's like, you shouldn't worry about this. What you should be doing is digging a bunker and storing canned foods, because this thing is like Terminator. It's coming for you. It can rotate like 360 degrees. And so it's got this really creepy way of moving. It's petrifying.
Did you visit the triennial exhibition at NGV, National Gallery of Victoria, earlier in the year? So they had this room set up, and there were 3 Boston Dynamics robot dogs. As an artwork, they kind of combined it with AI, and they roam around the display and do things all day long.
Yep.
One of the things they did was kind of like draw on the walls, these kind of artworks, and then slowly add to each other's artworks. And they'd also look out at you and kind of interact with the people who were looking in through the windows. It was amazing. Like, you could look at them for hours, and they don't drop hair like my golden retriever. So,
well, you could get a Labradoodle. My Labradoodle doesn't drop hair either, but I'm sure he does significantly less.
And they take themselves off to their charging station, and it's like they're having a little sleep. They just go off and charge themselves. It's cool.
I mean, in the last few months, there's been so many of these humanoid robot companies showing off their prototypes, which makes you wonder whether it's sort of the start of it actually going somewhere this time after 100 years of sort of playing around the margins. Anyway, radiologists, beware.
Absolutely. All right, should we wrap this episode up, Gaylard? How can people get in contact with us?
I think we should. Although I have to say, I feel like we haven't really.
Well,
this is almost been a host.
You mean you haven't? I did that panel. You're supposed to come into this outro with a couple of things you wanted to talk about. Like, you're supposed to go, oh, yeah, I remember a case of mucormycosis as well. And, I really loved it when Dan spoke about
So you want me to do,
that's what you're supposed to
do. Something, head and neck. They said it all. All right, well, we're at Radiopedia.
That's it. It's not that you were slack.
No, not at all. We are at Radiopedia on X and Instagram, as well as at Frank Gaillard and at Dr. Andrew Rickson. And
Andrew what? Andrew Rickson? You're like a robot dog. Andrew Rickson.
Well, there you go. So you can replace meat. and you can email us at podcast@radiopedia.org with any ideas and feedback, or just, if this podcast is anything to go by, completely random things.
I'm thinking it is actually time, given the very hostful nature of this episode today, of having an official hostful episode soon, Gaylard, where we have an excuse to actually ignore the topic of the day and just come up with random things. So if people listening can send in their reviews and questions for that, that would be awesome. I'm thinking maybe next episode, perhaps, unless the other thing that I'm working on comes through in time. Sound like a plan?
Sounds very good. I feel like I need a little therapy session.
Okay.
How I can aim to air my goats.
And I've also had an idea for what we should do on the podcast for this year's conference.
Oh, yes.
Gaylard. So last year we did 5 mini episodes, one for each day. But this year I'm thinking just 1 episode. You like that? But there's a big but coming.
A little bit ominous.
But we record a special 2-hour show. Right, that's the gimmick. It's got to go for 2 hours.
Okay.
Live with guests and video cameras on.
Oh, right? Video cameras on.
Yeah.
Oh, that does sound good. I'd probably need to get out of my dancing skeleton Udi.
Yeah.
I wonder if Udi...
No, it looks so good, mate.
Do you think Udis are an Australian company? I don't know.
Oh, surely not.
Maybe they could come up with a Radiopedia custom Udi for all those cold radiology reporting rooms around the world.
We've spoken about merchandise so much, and yet there is still no merchandise to be seen. And if you want to help support Radiopedia other than buying our mythical merchandise, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference coming up in July. In doing so, you'll be helping us to give free conference and course access to people in 125 low and middle income countries. And what else can people do to help out, Gaylord?
And you can also help out by leaving us a 5-star review in the podcast app of your choosing. Not just
Excellent.
anyone, like the one that you choose.
Yeah. We're not telling you what to do. I mean, we're telling you to give us 5 stars. But other than that, you can go
It's
wherever you
entirely
like
up
and
to
give us
you.
5 stars.
You could probably actually give us 5 stars on multiple apps of your choosing if you really wanted to.
Let's change that line for all future episodes. Help us out by leaving a 5-star review on every app that you have on your phone. Even Pornhub. And we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad.
All right. See you later. I'm looking forward to seeing Teen Wolf Gaylord on the speaker card.
Extra hair.
See you in a couple of weeks.
Bye-bye.